Started? Welcome back, guys. See you after a long time. So, in this today's class, let's begin with the macrocytic anemias and also let's do some normocytic anemias. Already in the previous classes, we have discussed about the microcytic anemias. Okay, the microcytic anemias, the examples of the microcytic anemias, which are the iron deficiency anemia, anemia of the chronic disease, and we have also discussed about thalassemia and sideroblastic anemia. Okay, so we have discussed about the microcytic anemias in the previous videos. Now in this today's class, let's discuss about the macrocytic anemia. First, let's begin with the macrocytic anemia. Okay. So let me 1 minute, guys. Let's begin. Yeah. Okay. So macrocytic anemias. See, what exactly do we mean by macrocytic anemias? In the name itself, it's there. Macro. Macro means what? Macro means big. Cytes means what? Big cells. Okay. So yes, anemia is there. Definitely anemia is there in the person. That too, the size of the RBCs are going to be very big. How much big, sir? How much big? To call it as a macrocytic anemias. See, the mean corpuscular volume of the RBC, the mean corpuscular volume, okay, is more than 100 femtoliters. Okay, more than 100 femtoliters. Now, let's see what are the causes of the macrocytic anemia. Why macrocytic anemia? Okay, causes. The first two important causes are B9 deficiency and B12 deficiency. So what is B9, sir? Folate. What is B12? Cyanocobalamin. Okay, cyanocobalamin. So vitamin B9 and B12 deficiencies. Okay, if there is macrocytic anemia, okay, again listen carefully. If there is macrocytic anemia due to B9 and B12 deficiency, then it is called as megaloblastic anemia. Okay, then it is called as megaloblastic anemia. Megaloblastic anemia is a type of macrocytic anemia, but due to B9 and B12 deficiency. Okay, now why the name megaloblastic? Okay, why the name megaloblastic anemia? Before going to that, explaining why it is megaloblastic anemia, first let's of all first write what are the causes of macrocytic anemias: B9 deficiency, B12 deficiency, alcoholism, okay, liver diseases, okay. So these are some important causes of the macrocytic anemia. First of all, why B9 deficiency and B12 deficiency? How it is going to cause megaloblastic macrocytic anemias? How it's going to cause this anemia? Look, guys, here B9 and B12, they are very much important. Okay, these vitamins are important for the production of DNA precursors. Okay, they are important for the production of DNA precursors. Or in a simple way, we can say vitamin B9 and B12 are very much important for the division of the cells. Okay, for the production of the DNA. So DNA will help in DNA replication, and like you know it, right? So first, for the cell division, what do you require? For the cell division, you require the DNA. DNA synthesis, DNA replication is needed. Okay, but for that you require the vitamin B9 and B12. So vitamin B9 and B12 is required for DNA precursor synthesis, so that cell division will happen. Okay, so during cell division only, DNA synthesis will happen, like the 2 copies is going to happen. Whenever there is vitamin B9 deficiency, B12 deficiency, DNA precursors are not there. Whenever the DNA precursors are not there, cell division is not going to occur. See, the one point which I want you to know is, actually, during the process of production of the RBCs, there are many steps. There are almost 7-8 steps are there, important steps. Now, the immature cells, they will divide, like the normoblast, early normoblast, intermediate, late normoblast. Okay, so there are so many stages. These are the immature cells. Now the immature cells, while they are dividing, okay, the immature cells while they are dividing, see, one thing what you can appreciate is the size of the cells are gradually getting reduced. The size of the cells is gradually getting reduced with every cell division. From immature cell, this is the immature cell, this is the mature RBC. Okay, this is a mature RBC, this is the reticulocyte. You can know the thing, okay? But the point which I want you to know is, as you are going in this direction, the size of the cells is getting gradually reduced. Now, what is happening? So, the vitamin B9 and B12 are not there. As the vitamin B9 and B12 are not there, DNA synthesis is not occurring, DNA precursors are not occurring, so cell division is not properly occurring. As the cell division is not properly occurring, what happens? Now, the immature cells are not going to be converted into the mature cells. So, immature cells are called as blasts, you know it. Blasts are immature cells. Blasts are going to be big in size. So, that's why the name megaloblastic, mega means big, blastic means blast cells are there. Why anemia? Because you know it. First of all, the cell division is not happening. Okay. So, hematopoiesis, RBC production is getting affected because of vitamin B9 and B12 deficiency. And that too, what kind of cells you are having? Immature cells are seen in the peripheral smear. As a patient is having anemia, the RBC is in a rush. Okay, RBC is in a rush to produce more, release more and more RBC. In that process, more immature cells are being released into the bloodstream. So, in the peripheral smear or in the peripheral blood, what you can see is the immature cells. That's why the megaloblastic anemia. Okay, so this megaloblastic anemia can be because of vitamin B9 or vitamin B12 deficiency. We have already discussed. Okay, now let's see why B9 deficiency. Okay, B9 deficiency anemia. See how to find out whether it is B9 deficiency anemia or B12 deficiency anemia. See, both of them can cause megaloblastic anemias. Both of them, B9 can cause megaloblastic anemia, B12 can cause megaloblastic anemia. It's not just the combo. They can individually cause the megaloblastic anemia. First, let's discuss about the folate deficiency anemia. Okay. First of all, from where you will get these folates? See, these folates, you will get it from the fruits and vegetables. Okay, you will get it from fruits and vegetables. Now, this folate, where it is getting absorbed? The folates are vitamin B9, the folic acid is absorbed in jejunum. Okay, jejunum. Okay, that's also cool. Now, once the folate comes into your body, in a simple way, you can understand the folate is going to be methylated. Okay, now the folate will be methylated. Folate will accept the methyl group. See, H3, methyl group. So, it becomes methyl tetrahydrofolate. Okay, methyl tetrahydrofolate. Okay, methyl tetrahydrofolate. Now, say this methyl tetrahydrofolate, it is not helpful in the DNA precursor synthesis. Okay, whenever this methyl group is there, it's not going to be helpful. Okay, now in order to participate, we don't want methyl tetrahydrofolate. Tetrahydrofolate is good. What we want is tetrahydrofolate, but we don't want it methyl. Before entering into the DNA precursor synthesis, this methyl group need to be donated to some other methyl acceptor. So, who is going to accept this methyl group? This methyl group is transferred to vitamin B12. Okay, from the B9, this is B9. Okay, the methyl group is accepted to the cyanocobalamin. Now, this cyanocobalamin is having methylated. Okay, methyl, it's methylated. See, this B12, it's a methyl donor. Okay, it's a methyl donor. It will donate this methyl group. To whom? It's going to donate this methyl group to homocysteine. So, by accepting this methyl group, the homocysteine is going to be converted to methionine. See, why I am talking about all this biochemistry is because you will understand how to identify the folate deficiency anemia. Okay, so folate after entering into the body, it becomes tetrahydrofolate, which accepts the methyl group, becomes methyl tetrahydrofolate. But to participate in DNA precursor synthesis, the methyl group need to be donated to vitamin B12. So, vitamin B12 accepts methyl group and it will donate it to again homocysteine. By accepting the methyl group, the homocysteine will be converted into methionine. Done. Okay, it's done. Just keep this point in mind. Now, look here. Now, After donating the methyl group, it becomes tetrahydrofolate. Now this tetrahydrofolate, now it is going where? Now where it will go? It will go to tetrahydrofolate. It will help in DNA precursor synthesis. It will help in DNA precursor synthesis. Done. Now, let's talk about B9 deficiency anemia. Okay, B9 deficiency anemia. See, who will get this vitamin B9 deficiency anemia? Okay, causes. Okay, alcoholics. Okay, so alcoholics are going to get vitamin B9 deficiency, malabsorption. Alcoholics are going to have the malabsorption. So absorption of vitamin B2, B9 is not going to occur properly. Who else is elderly people? Okay, these people can become vitamin B9 deficient. Okay, guys, see which people can get vitamin B9 deficiency? Those people who are having vitamin, who are having these habits like alcoholism, or elderly, and pregnancy. Why during pregnancy? During pregnancy, there is a baby growing in the uterus. The baby is completely growing, right? Cell division is occurring in the baby. So cells are dividing in the baby. They will take up all the vitamin B9. So relatively, the mother will become vitamin B9 deficient. Okay, and cancer. So cancer patients, why cancer? You know it, cancer is uncontrolled growth of the tissue, uncontrolled growth of the cells. So cells are dividing. As that dividing means more cell division is happening, more DNA synthesis is happening, more DNA replication. For that process, all the vitamin B9, whatever is there, will be consumed. Okay, and during the pregnancy, the baby is taking up all the vitamin B9. During cancer, the cancer cells are using the vitamin B9, so patient can get vitamin B9 deficient. Okay, and malabsorptions like which can be seen in alcoholics, we have seen. And for example, Crohn's disease. Why Crohn's disease? Malabsorption syndrome. Okay, inflammatory bowel diseases, malabsorption can occur. Crohn's disease. Celiac sprue. Same, there is loss of villi from the intestines, there is a loss of villi from the duodenum and jejunum. So that can cause the malabsorption. Okay, they are rare causes, but they can also still cause. Okay, alcoholics, elderly, pregnancy, cancer, and certain drugs like 5-fluorouracil, methotrexate. Okay, these are folate inhibitors. Okay, so folic acid reductase, dihydrofolate reductase inhibitors. Okay, these are the methotrexate, dihydrofolate. See, in the name itself, it's a dihydrofolate vitamin B9 reductase inhibitors. Okay, dihydrofolate reductase inhibitors. See, these drugs can also cause vitamin B9 deficiency. Okay, sir, at the end of the day, vitamin B9 deficiency occurred. So what happens? You know it, vitamin B9 is not there means no DNA synthesis, no DNA precursors, no cell division, so megaloblastic anemia. See, one thing which I want you to know is not only megaloblastic anemia, what you can say is hypersegmented neutrophils in the labs, in the peripheral sphere, what you can say is hypersegmented. Okay, hypersegmented neutrophils. Okay, hypersegmented neutrophils. So why hypersegmented neutrophils? Hypersegmented neutrophils are nothing but the immature neutrophils. They are also like a blastic cells. A proper neutrophil will have 2 to 5 lobes. Okay, 2 to 5 lobes or 3 to 5 lobes. Okay, nuclear lobes. Usually you know it, right? The neutrophil is going to have multilobated nucleus. A mature neutrophil is going to have 3 to 5 lobes or 2 to 5 lobes somewhere. But if you have more than 5 lobes, then it is called as a hypersegmented neutrophil, which is nothing but a immature cells. So such kind of neutrophils are going to be seen. For example, look here. There is 1, 2, 3, 4, 5, 6, 7. There are 7 lobes which are seen in this neutrophil. So this is hypersegmented neutrophil. And not only that, you can very clearly appreciate, see the size of the RBC. The size of the RBC is also big. How much big? More than 100 fematoliters. More than 100 fematoliters. Megaloblastic anemia. Okay. So how can we say? So this megaloblastic anemia is because of the B9 deficiency. How we can say that this is because of vitamin B9 deficiency? See, I have already explained you. Look, vitamin B9 is the one which donates the methyl group to the vitamin B12. From the vitamin B12, the methyl group is getting transferred to homocysteine. Without B9, tell me, without B9, what happens? Without B9, the methyl group is not getting transmitted to vitamin B12, and from there it's not going to the homocysteine. So now when vitamin B9 is not there, homocysteine is not going to be converted to methionine. So what happened to homocysteine levels? The serum homocysteine levels are elevated. Okay, so hypersegmented neutrophils are seen, true. Homocysteine levels are going to be more. Now, next thing is, if you check the serum methylmalonic acid levels, they are normal. Okay, serum methylmalonic acid levels, methylmalonic acid levels are going to be normal. Why they are normal? Because we'll understand in the topic of vitamin B12. Okay, in the topic of vitamin B12 deficiency anemia, there I will explain you. For now, just remember, the serum methylmalonic acid levels are going to be normal, because the serum methylmalonic acid levels will be elevated. It will be elevated. It is used to differentially diagnose vitamin B9 deficiency anemia from vitamin B12 deficiency anemia. Here, it is normal, but in B12 deficiency anemia, it will raise. Why it will raise? I will explain you. Okay, why it will raise? I will explain you. So, what I want you to know is hypersegmented neutrophils are seen on the peripheral smear. In the blood, serum homocysteine levels are elevated. Serum methylmalonic acid levels are going to be normal. And here in this fellows, what else I want you to know is, sir, no neurological, okay, labs are completed, no neurological symptoms. Okay, no neurological symptoms are seen. Okay, why I'm telling you this? Because in vitamin B12 deficiency anemias, neurological symptoms are going to be seen. Okay, now after this, what else I should teach you is, so these patients usually have glossitis. Okay, glossitis will be seen in B9 deficiency, because B9 is needed for the cell division. Here cell division is not occurring, so even the cells which are present on the tongue are also not properly getting replenished, so there will be atrophic glossitis will be seen. Okay, so this is how we'll differentiate between vitamin B12 deficiency anemia as well as these are the points which I want you to know regarding B9 deficiency anemia. After this, let's quickly start about the vitamin B12 deficiency anemia. Vitamin B12 deficiency anemia. The vitamin B12 cyanocobalamin, the important point which I want you to know is that this vitamin B12 is only having animal source. It's having only animal sources. Okay, usually we have enough amount of vitamin B12. Usually patients won't go into the vitamin B12 deficiency. Usually we won't go into the vitamin B12 deficiency until unless the person is a pure vegan. Okay, not even vegetarian, vegans, like those persons, those people who doesn't consume any animal product. Okay, not just even the meat, like they won't even take the dairy products like milk, like milk, cheese, butter or ghee kind of thing. Okay, they won't take any milk related product or any animal related product. So these people can end up in vitamin B12 deficiency, because vitamin B12 is having only animal source. We will get vitamin B12 only from the animals. The point which I want you to know is, so once you take vitamin B12, the vitamin B12 is going to bind with R binder. Okay, R binder in the saliva. Now this vitamin B12 R binder complex, it is going to come into your stomach. Okay, now from the stomach it is going to come to the duodenum. Okay, now it's coming where? It's in the duodenum. Now in the duodenum, the vitamin B12 is going to bind with intrinsic acid. Intrinsic factor, not acid, intrinsic factor. Now you will get a question, sir, what is this intrinsic factor? Where it is happening? It's happening in the duodenum. Now in the duodenum, the vitamin B12 R binder complex is going to be cleaved. Okay, it's going to be cleaved, separated. Now vitamin B12 is going to bind with the intrinsic factor. Question is, from where this intrinsic factor is coming? The intrinsic factor, it is coming from the parietal cells. What are these parietal cells? The parietal cells are the acid producing cells. These are the acid producing cells in the stomach, gastric mucosa. Okay, in the gastric glands there are parietal cells. In the gastric glands there are parietal cells. These parietal cells produces acid. Okay, they will produce acid as well as intrinsic factor. Okay, it will produce intrinsic factor. Now this vitamin B12 intrinsic factor complex. Okay, now B12 intrinsic factor complex, it is only B12 is absorbed. See, only vitamin B12 is absorbed along with intrinsic factor. Now this complex is going to be absorbed where? In terminal ileum. Okay, in terminal ileum vitamin B12 is absorbed. This is something normal. It's something normal. So what are the causes of vitamin B12 deficiency anemia? Okay, the causes. One cause you already know it. Okay, vegans. So those persons who are not at all taking any animal related product can get vitamin B12 deficiency anemia. Second, the most important for your exams is pernicious anemia. Pernicious anemia. So what is this pernicious anemia, sir? Pernicious anemia, it's an autoimmune condition. It's an autoimmune condition. What exactly is this? So in pernicious anemia, autoantibodies, look, the autoantibodies are produced against the parietal cells. So parietal cells are going to be damaged, destroyed. When parietal cells are damaged, the intrinsic factor is not going to be present. Okay, intrinsic factor is not going to be present. Without intrinsic factor, do you absorb vitamin B12? No, vitamin B12 absorption cannot happen. So pernicious anemia is one of the cause, is the most important cause of vitamin B12 deficiency anemia. Okay. Next, what else is certain parasites? Okay, so something called as Diphyllobothrium. Diphyllobothrium latum, which is fish tapeworm. See, this Diphyllobothrium latum, which is also called as a fish tapeworm, okay, it lives in the terminal ileum. Where it will live? It lives in terminal ileum. As it's living in terminal ileum, it causes inflammation over there and it interferes with the absorption of vitamin B12. It inhibits the absorption of vitamin B12 because it causes inflammation. In the inflammatory conditions, the vitamin B12 absorption is going to be affected. So Diphyllobothrium latum can cause megaloblastic anemia or vitamin B12 deficiency anemia, which is also called as botryocephalus anemia. Okay. Next, what else? Crohn's disease. Crohn's disease. Crohn's disease malabsorption conditions. Any malabsorption condition which affects the terminal ileum can be affected. Okay. So these are some important causes. Okay, these are some important causes for vitamin B12 deficiency. Now let's see the labs. What you will see in the labs? In the labs, one thing is hypersegmented neutrophils. Okay, hypersegmented neutrophils are seen. You have seen the image, like the immature neutrophils with multilobated nucleus. That's a hypersegmented neutrophils. Second one is, again, look here, guys. As vitamin B12 is not there, see in vitamin B12, if it is not there, again it's not going to give the CH3 methyl group. It's a vitamin B12 which donates the methyl group to the homocysteine. So that homocysteine will be converted into methionine. Now as vitamin B12 itself is not there, okay, methyl group is not going to homocysteine. Again, even in this condition, vitamin B12 deficiency anemia also, homocysteine levels are elevated in these persons. The homocysteine is the one which causes the damage. Okay, homocysteinemia. Now there is more homocysteine. Homocysteine is the one which causes the damage to the endothelial cells. So it can lead to thrombosis. Okay, endothelial cell damage. Endothelial cells, once they are damaged, they will form the thrombosis. You know the Virchow triad. Okay, 3 conditions which can cause the thrombosis. That is endothelial injury, alteration in the blood flow, that is either stasis or turbulence or hypercoagulable state, all can cause thrombosis. So here homocysteine causes the endothelial damage. Let me write here, endothelial damage, that can cause thrombosis. This thing. And the point which I want you to know is vitamin B12 is very much important for the conversion of methylmalonic acid. Okay, the methylmalonic acid need to be converted into succinyl coenzyme A. Okay, for this conversion, you require vitamin B12. As vitamin B12 is not there, the methylmalonic acid levels will increase. So, methylmalonic acid levels are increased. Now, this methylmalonic acid, it accumulates within the neurons, okay, within the myelination. So, this methylmalonic acid will cause damage to the neurons. Damage to neurons. Okay, so that will cause neurological symptoms. Okay, that will cause neurological symptoms. So, this condition is called as, these patients who are having severe vitamin B12 deficiency, the neurons will be affected, especially the neurons in the posterior column. Okay, if you look at the spinal cord, you know it. This is the posterior column of the spinal cord. Okay, so this is the posterior column, right? Here you are having the advanced sensations. Okay, in that area the advanced sensations are going. Okay, so those ascending tracts which are carrying the advanced sensations like vibration, proprioception, okay, senses. So here these neurons are also highly myelinated. So now this methylmalonic acid is accumulating within the neurons and causing damage. Okay, so this condition is called as subacute combined degeneration. Subacute combined degeneration of spinal cord, where the patients are losing advanced sensations. Advanced sensations. Because you know it, sir, here in this column, the primitive sensations are traveling. In the lateral column and the anterior column, primitive sensations like touch, pain, temperature, pressure are traveling. But in the dorsal column, okay, in this dorsal column, advanced sensations are traveling like fine touch, vibration, proprioception, 2-point discrimination, advanced sensations are traveling. So the person is going to lose these advanced sensations. Okay, so hypersegmented neutrophils are seen, homocysteine levels are going to be elevated, serum methylmalonic acid levels are elevated, and the neurological symptoms are seen. So how to differentiate vitamin B9 deficiency anemia with vitamin B12 deficiency anemia? All the clinical features, all things are going to be same, but neurological symptoms is a one different, and the methylmalonic acid levels will differentiate vitamin B9 deficiency anemia from vitamin B12 deficiency anemia. Okay, so done. Now after this, let's discuss about normocytic anemias. Between B9 and B12 deficiency anemias are completed. Now normocytic anemias. So yes, the patient is having anemia, but the size of the RBCs are normal, normocytic. Normocytic is here in the cells. The size of the RBCs is between 80 to 100 femtoliters. Normocytic anemias. Okay. Now, question is, why anemia? Why there is anemia? Due to vitamin B9 deficiency, B12 deficiency, iron deficiency? No. Here, why anemia is because two reasons. Either the RBCs are getting destroyed. RBCs are getting destroyed. Okay. So, peripheral destruction. Okay, the RBCs are getting destroyed. Or RBCs are not getting produced. Not produced. Okay, that is underproduction. Either the RBCs are getting destroyed, that's a peripheral destruction, anemias, or the second cause for the normocytic anemias is underproduction. Okay, the RBCs are not getting produced. First, we'll discuss about the peripheral destruction. What is this? See, peripheral destruction means there is no problem with the RBC production. No problem with the RBC production. RBCs are getting produced normally. Okay, no problem with the production. But the RBCs are getting destroyed. Where the RBCs are getting destroyed? In two places. The RBCs, they can destroy in their natural place, that's the spleen, the reticuloendothelial system, that is the spleen, lymph nodes and liver. That is extravascular. The peripheral destruction can be extravascular. Extravascular means not within the vessels, but within the spleen or in the lymph nodes and the liver. Extravascular hemolysis is happening. Or hemolysis can happen within the blood vessels itself. within the blood vessels itself, that is intravascular. Okay, so now tell me, how many types of hemolysis are there? Two types, extravascular hemolysis or intravascular hemolysis. Hemolysis, in the name itself, it's there, hemolysis, RBC breakdown. Okay, hemo means blood, breakdown. Okay, lysis means breakdown, RBCs are getting breakdown. Okay, so now without any further late, first begin our topic with peripheral destruction anemias, that too extravascular. Okay, extravascular peripheral destruction anemias. Extravascular hemolysis. Now, before going to tell you the examples of extravascular hemolytic anemias, first let me explain you how the labs are going to change. Okay, how to identify this is the extravascular hemolytic anemia. Okay, now first tell me where the hemolysis is happening. Hemolysis. Because of some reason, I will tell you what is the reason. Because of some reason, hemolysis is happening where? Hemolysis in spleen. In spleen, the macrophages. Okay, splenic macrophages. The splenic macrophages are causing the hemolysis. Now, more and more RBCs are getting turned over, right? Now, unnecessarily, if RBC have to like die at 120 days, but now unnecessarily at 40 days or 50 days, RBCs are getting died. Okay, so more RBC destruction will release hemoglobin. Hemoglobin is going to split into globin, that's a protein, and heme, this is non-protein. Globin will be broken down into amino acids that will be used by the body. Now, what about this heme? Heme is further broken down into iron, which will be used by the body, and protoporphyrin. Now, this protoporphyrin, we don't want it. Okay, the protoporphyrin, it will be converted into, okay, protoporphyrin, it is converted into, or breakdown into something called as unconjugated bilirubin. Okay, unconjugated bilirubin. So now the unconjugated bilirubin levels are going to be more. Okay, more unconjugated bilirubins. So the point which I want you to know is those persons who are having extravascular hemolytic anemias like hereditary spherocytosis or sickle cell anemia. Okay, now itself I am telling you the examples that we are going to discuss about the extravascular hemolytic anemias. Two things, that is hereditary spherocytosis. Okay, hereditary spherocytosis and sickle cell anemia. In both these conditions, it's the same thing. It's both these conditions is the same thing. Now, more and more hemolysis, extravascular hemolysis. So, more and more protoporphyrin. That more protoporphyrin will be converted into unconjugated bilirubin. So now this unconjugated bilirubin, it's the one which is going to cause jaundice symptoms. Okay, it's going to cause jaundice. Now, this unconjugated bilirubin, yes, at the end of the day, it's going to the liver, and where it's getting converted, the unconjugated bilirubin, your liver will try to convert it to the conjugated bilirubin for excretion in the urine. So, the unconjugated bilirubin will be converted into conjugated bilirubin. So, now this conjugated bilirubin levels are also more. Now, where this conjugated bilirubin is going? Sir, it is going into bile. It's going to bile. So, in the bile, the conjugated bilirubin levels are going to be more conjugated bilirubin. Now, this conjugated bilirubin is going to form the stones. It will bind with the calcium, forms calcium bilirubinate. Now, it forms the calcium bilirubinate and forms the stones. So, it forms gallstones. These gallstones are going to be little black in color. These are called as pigmented. Okay, pigmented gallstones. So, the point which I want you to understand is those persons who are having extravascular hemolytic anemias like hereditary spherocytosis and sickle cell anemia, they are at a risk of developing pigmented gallstones because of calcium bilirubinate precipitation. Okay, done. Next, here one point I have actually forgot to mention you is, say, how to differentiate between peripheral destruction anemias and underproduction anemias. Let me write a better word rather than writing not produced, underproduction. Okay, so how to differentiate between peripheral destruction anemias or underproduction? See, we use reticulocytes. Okay, we use reticulocytes. So what are reticulocytes? Reticulocytes are the immature RBCs. Okay, immature RBCs. Now use your logic. Now imagine I am the person who is having more peripheral destruction. Okay, in my spleen the RBCs are getting chopped off. They are getting damaged, totally destroyed. Now what my bone marrow will do? How my bone marrow is going to react? As there is severe hemolysis, the bone marrow will try to compensate. Bone marrow is absolutely normal. Bone marrow is trying to produce more and more RBCs. During this rush, they will release more and more immature cells into the circulation. So bone marrow is working hard. So it's releasing more and more immature cells. So more and more immature cells means more and more reticulocytes. So reticulocytes usually they are less than 2%. Okay, usually they are less than 2%. If it is peripheral destruction anemia, okay, if it is a peripheral destruction anemia, reticulocyte count is going to be more than 3%. If it is underproduction anemia means bone marrow is not producing properly. Then in these conditions, reticulocyte count, okay, the reticulocyte count is going to be less than 3%. If it is less than 3%, it is underproduction anemia. If it is more than 3%, it is peripheral destruction anemia, either extravascular hemolysis or intravascular hemolysis. Okay. So done, completed. Now let's begin with the peripheral destruction anemias. Like let's take the example. Okay. So let's take first thing, that is hereditary spherocytosis. So what exactly is this hereditary spherocytosis? Hereditary in the sense, in the name itself it is inherited. Okay, inherited. Spherocytes means what? Sphere means spherical, round shape cells, round cells. Round cells. What are these round cells? RBCs. These round cells are nothing but RBC. What's the defect, sir? See, this is how your RBC should be. Okay, this is how your RBC should be. Means nice and flexible biconcave shaped RBCs. Okay. This biconcave shape is because of some peripheral proteins called as spectrin. Okay. Spectrin and ankyrin. Spectrin and ankyrin. These are the peripheral proteins in the RBC cell membrane which is responsible for the biconcave shape. Whenever there is a defect in these peripheral proteins, especially with the ankyrin, okay, ankyrin defect will cause hereditary spherocytosis. Okay, it's going to cause the hereditary spherocytosis. Now, because of this defect, now this RBC membrane is not going to be tough. Okay, it's not going to be tough. So what happens is, it's not going to be tough, it's not going to be proper. So this RBC is going to become loose and this RBC is going to form such kind of blebs. Okay, means not proper shape. Now when such defective RBCs, when they are passing through the spleen always want good RBCs. When spleen or splenic macrophages, when they see such RBCs, defective RBCs, now this membrane will be removed, this extra blebs, okay, that extra pouches whatever were there, they will be removed. So during this process, continuously every minute the blood is going through the spleen. So the RBCs are caught up by the splenic macrophages and this extra membrane is getting removed. So during this process, because of the defect in the ankyrin, because of the membrane protein defects, okay, it's a membrane protein, ankyrin is a membrane protein, because of the defect in the membrane protein, the RBCs at the end of the day, they will attain round shape. Okay, so RBCs are becoming rounded, not biconcave, rounded in shape. What's the problem? The problem is such round RBCs, they are not flexible. They are functional, no doubt, they are absolutely functional. Their hemoglobin is also normal, they are doing their job. But splenic macrophages doesn't like this round RBCs. Okay, they cannot easily pass through the, they cannot go through the splenic sinusoids easily. So they will be blocked, they will be caught up by the splenic macrophages and splenic macrophages are going to destroy such RBCs. So what's happening? There is no problem with the production. But because of the defect in the membrane proteins, the RBCs are getting round in shape and they are getting destroyed in the spleen. So extravascular hemolysis. Okay, so hemolysis. Okay, so this is the point which I want you to know. Hemolysis, that's going to cause anemia. Okay, that's going to cause anemia. So hereditary spherocytosis, extravascular hemolytic anemia. Now, what you will see in the labs? Okay, what you will see in the labs? First, spherocytes. Okay, spherocytes means round shape RBCs. Let me show you if possible. See here. See, this is the RBC which is absolutely round in shape. Now, if you are good enough, if you are good student, you can appreciate something. Let me show you. For example, see, this is a normal RBC. See, in a normal RBC, you will be having a central pallor. Okay, that white color will be there. The central pallor is going to be there. Now, as the RBC is losing its membrane, the RBC membrane is getting lost. Now, the RBC is becoming round. Now, it's a round shaped RBCs. Actually, let me tell you. See, if this is the RBC, biconcave shaped RBC, these are the areas, the peripheral areas are the place where hemoglobin is going to be concentrated. Okay, this is the area where the hemoglobin is getting concentrated. So, in the center, the hemoglobin is not there. So, in the center, you will see that paleness. That paleness is going to be seen. Okay, so the periphery is going to be more reddish in color. But when you lose that shape, now the RBC is becoming round. So there is equal distribution of the hemoglobin. So the entire RBC is going to look red. So look, the entire RBC is looking red, sir. There is loss of central pallor. So first, let me write one by one. What you can see is spherocytes are seen. There is loss of central pallor. Third one is mean corpuscular hemoglobin concentration. The concentration of the hemoglobin. The cell is losing its membrane. The cell is losing its membrane. Now it's a round cell. So what's happening to the relative hemoglobin concentration? Relatively the hemoglobin is getting concentrated because you are taking out the membrane. So cell is now getting little small, not too much small, little small. So the hemoglobin concentration, corpuscular hemoglobin concentration is going to raise. So this is actually a keyword. The moment you see the mean corpuscular hemoglobin concentration, that's increasing, you can say this is hereditary spherocytosis, sir. Okay, so this is the one thing which you can see in the labs. And fourth thing is unconjugated bilirubin. Unconjugated bilirubin is going to be elevated, you know it, because in the spleen more and more RBCs are getting broken down, more and more hemolysis, more unconjugated bilirubin production. That unconjugated bilirubin is the one which is going to cause the jaundice and gallstones. It's going to cause jaundice and gallstones. Now, apart from this, what else you can see? Not from the labs. Generally, when you do the physical examination, you can see a bigger spleen. Spleen is now doing more work. Okay, it's work hypertrophy. The spleen is doing more job now. More hemolysis continuously throughout the day. There is hemolysis happening. So what you can say is splenomegaly. Okay, these patients are having splenomegaly, sir. Next, what else you can appreciate in these patients is, see, there is a test called as Nestrov test. Okay, Nestrov, naked eye osmotic fragility test. Okay, so osmotic fragility test. So what is this osmotic fragility test? You know about the osmosis, right? Water will move from high osmolarity to, the water will move from low osmolarity to high osmolarity. For example, okay, let me give you example so that you can understand. See, I am keeping here plasma, or let me put it this way. I am taking here hypotonic solution. Hypotonic. Hypo to what? Hypo to our plasma. Our plasma osmolarity is 300. Okay, now maybe this is 200 or 100. Hypotonic solution I am taking. Now I am just keeping here one RBC. Now RBC is it's present in our blood, so its osmolarity is somewhere around 300. Now Inside the RBC there is high osmolarity. Outside there is low osmolarity. So you know it, water will move from high low osmolarity to high osmolarity. Water will move from low osmolarity to high osmolarity. Water, wherever there is sodium, water moves towards the sodium. So wherever there is high osmolarity, okay, wherever there is high osmolarity, water is moving towards that. See, normal RBCs are having enough space. They are having extra membrane, that biconcave shape is there. Now they will take up the water and they will swell. There is no problem. They will swell. Okay, they can take up the water. They are having extra space. They will take the water and they will swell, no doubt. But if you take a spherocyte, see here again I am taking the same solution, hypotonic solution. Okay, now I am keeping here a spherocyte. See, already spherocyte, it is losing all its membrane. Now it is already round in shape. Okay, it does not have any extra space to take this water. So now what do you think? Can it accommodate this water? No, it does not have the space, but water is going into the cells because of the osmolarity. So water will enter into the cell and will cause the rupture of the cell. So these cells are fragile. When you keep these cells in hypotonic solution, they will undergo lysis. That is called as osmotic fragility test. So osmotic fragility test is done for hereditary spherocytosis, where the spherocytes are fragile. Okay, so that's the point which I want you to know. Next, these patients are having throughout the day 24/7 in the spleen, there is hemolysis happening. Okay, hemolysis 24/7, hemolysis happening 24/7. As there is hemolysis, what your bone marrow will do? Bone marrow will try to produce more number of RBCs. Bone marrow is trying to react. So what happened to reticulocyte count? Reticulocyte count is going to be more than 3%. So it's not underproduction anemia, it's a over destruction anemia or peripheral destruction anemia. So reticulocyte count is going to be more. During this process, the spleen is releasing more and more immature cells. More and more immature cells are getting released. Normally in a mature RBC, there is no such thing as DNA or nucleus. There is no nucleus in a mature RBC. But during this process, as more and more immature cells are coming into the circulation, some RBCs will have the nuclear fragments. For example, if this is the RBC, immature RBC, it will still have some nuclear fragments. So these nuclear fragments which are there, these are called as Howell-Jolly bodies and they can be seen. So Howell-Jolly. Howell-Jolly bodies. Okay, Howell-Jolly bodies. So what are these Howell-Jolly bodies? They are nothing but the nuclear fragments which can be seen. So this is also completed. So one important point which I want you to know is that these patients are having continuous destruction. 24/7 there is continuous destruction. See, in my body, look, in my body right now, if you stop RBC production, just now you stop the RBC production, do you think I am going to have severe problems? No, because whatever the RBCs were there, they can live for a certain time. An RBC can live up to 120 days. Okay, with the whatever the amount of RBCs that I am having, I can survive. But it's not true with these patients who are having hereditary spherocytosis. Why? Because there is continuous destruction. Throughout the day, 24/7, there is a destruction. Okay, production is there, but destruction. Because of some reason, if you stop the production, they will go into crisis. So the point which I want you to know is these patients will have something called as aplastic crisis can occur in this patient with with parvovirus B19. See, this parvovirus B19 is going to affect the bone marrow. It's going to affect the bone marrow and it's going to stop the hematopoiesis. It's going to stop the hematopoiesis. The entire hematopoiesis is going to be stopped. Of course, it's a self-limiting condition. But this patient could not afford it because there is peripheral destruction. There is a chance that these patients can get parvovirus B19 infection that can lead to aplastic anemia. Aplastic anemia means no production, gone. Oh, on one side over destruction, other side aplasia, no production. Okay, so this is an important point which I want you to remember. Next, after this, the second type of anemia that I am going to discuss in the topic of extravascular hemolysis. Don't forget, in the extravascular hemolysis, I am going to discuss about two, hereditary spherocytosis and sickle cell anemia. Without any further late, let's begin with sickle cell anemia. Okay, sickle cell anemia. So why this sickle cell anemia? See, this is a qualitative problem. Okay, sickle cell anemia, it's a qualitative hemoglobin problem. Let me write one by one. It's an autosomal recessive condition. Okay, it's a qualitative, not quantitative. Quantitative is thalassemia. It's a qualitative hemoglobin defect. Okay, there is a defect in the quality. So what is the problem, sir? Where is the problem? See, the problem is in hemoglobin, globin, right? Okay, in the globin, the beta globin chain. Okay, see, beta globin is a protein. For the every protein there will be a gene, right? There will be a gene. So in the beta globin gene, there is a point mutation. Point mutation, small mutation. What is that point mutation, sir? The point mutation is, sir, the glutamic acid. Okay, the glutamic acid is replaced with valine. Glutamic acid is replaced with valine. See, glutamic acid is hydrophilic. Okay, and valine is hydrophobic. So we can say, sir, in sickle cell anemia, what happened is there is replacement of one amino acid, hydrophilic amino acid, that is glutamic acid, is replaced with a hydrophobic amino acid. Okay, so this is the problem, sir. Because of this mutation in the gene, see, there is a mutation in the gene. Because of the mutation in the gene, what happened in the protein? Okay, in the protein, which protein? Beta globin. What happened? Because of the point mutation in the gene, here glutamic acid is replaced with valine in the protein. Okay, proteins are made up of amino acid. Because of, instead of one amino acid, there is a total different type of amino acid. Now, do you think it's a normal hemoglobin? Definitely not normal hemoglobin. Normal hemoglobin is HbA. Okay, this is HbA is a normal hemoglobin which is having 2 alpha, 2 beta, normal. But here it is not normal. It is HbS. This is sickle cell hemoglobin. This is sickle cell hemoglobin, sir. Okay. Point which I want you to know is, see, the sickle cell people during intrauterine life. Okay, during intrauterine life, there is no problem for them. Why there is no problem for them is because they are having which type of hemoglobin? HbF, which is made up of 2 alpha, 2 gamma, alpha 2, gamma 2. There is no beta chain at all. There is no beta globin at all. Okay, so they won't have any problem during intrauterine life. But during adult life, they will have the problems. Because of the sickle cell hemoglobin, they are going to have the problem. Why problem? Why sickle cell hemoglobin? What is the problem with sickle cell hemoglobin? Is, let me write, sir, whenever there are certain conditions in the body like hypoxia. Okay, whenever there is hypoxia, dehydration. Okay, normally sickle cell hemoglobin is normal. Normally it is there. Okay, everything RBC is there, sickle cell like hemoglobin is there. But in these conditions like hypoxia, dehydration and acidosis, in these conditions will cause the precipitation of the sickle cell hemoglobin. Okay, they will cause precipitation of sickle cell hemoglobin. Now there is precipitation. Now the hemoglobin, it is going to precipitate and it forms the needle-like structures. It forms needle-like structures. See, now these needle-like structures are the one which is going to cause the membrane damage. Okay, so RBC membrane is getting damaged. So if the RBC membrane is getting damaged, do you think spleen will just look at it and just leave it? So it's not going to leave it. Okay, the spleen is not going to leave such damaged RBCs. So such damaged RBCs will be caught up by the spleen. So in the spleen, the macrophages, okay, in the spleen, the macrophages are going to cause the hemolysis. Question is, why? See, normally when the RBCs are in the major arteries, there is no problem. But in the tissues, we know it, at the level of our tissues, there is hypoxic conditions. There is little acidosis. So at the level, when the RBCs are going to go through the tissues, they will become sickled. There is hemoglobin precipitation. There is sickling. Okay, that precipitation of the hemoglobin is going to cause, sickle shaped RBCs. And when the same RBC, when it is coming to the normal circulation, it becomes desickled. So sickling, desickling, sickling, desickling. So this causes the RBC membrane damage. So RBC membrane damage is going to cause the hemolysis. So let me show you. You can clearly see here. See, so these are the sickled RBCs. Okay, these are the sickled RBCs. The classical thing. This is the sickled RBCs. So the sickled RBCs is because of the precipitation of the sickle hemoglobin, sickle cell hemoglobin. Why sickle cell hemoglobin? Because of replacement of hydrophilic amino acid with hydrophobic amino acid due to point mutation. Okay. So what else I should teach you regarding sickle cell anemia? See guys, these patients are also having continuous throughout the day 24/7 hemolysis happening. One point I forgot. What is the treatment of hereditary spherocytosis? I haven't taught you the treatment. The treatment of hereditary spherocytosis is, where is the hemolysis happening? The round shaped RBCs. Where that hemolysis? In the spleen, right? So remove the spleen, splenectomy. Okay, remove the spleen. So splenectomy is the treatment of hereditary spherocytosis. Okay, let's come back to the topic. Now, what I should teach you in sickle cell anemia. See, what happens is the sickle celled RBCs, okay, the sickle celled RBCs, they cannot pass through the blood vessels, okay, they cannot pass through the capillaries and they will cause occlusion, vaso-occlusion. So, right, sickle cells causes vaso-occlusion, okay, vaso-occlusion. So, vaso-occlusion within the digits, okay, will cause dactylitis. Okay, so the baby is going to have pain in the fingers, that is called as a dactylitis. Next, what else you should know is, so the sickle cell RBCs, they will block the blood vessels to the spleen also. In the spleen, these RBCs will block the blood supply. They block the blood supply to the spleen. So spleen, as there is no blood supply, it will die. So autosplenectomy. Okay, gradually there is decrease in the blood supply to the spleen, that causes autosplenectomy. So as spleen is not there, spleen is the site where the lymphocytes are going to mature, right? So as the spleen is not there, these patients are at a risk of infections. Okay, capsulated organism infections is at a risk of infections from the capsulated organisms. So autosplenectomy can be seen, dactylitis can be seen. So blockage of the blood vessels to the bones can cause osteomyelitis. Okay, osteomyelitis. Blockage of the blood flow to the kidneys can lead to renal papillary necrosis. Okay, renal papillary necrosis. So you know, right, in the kidney, already in the medulla region, see, these are the renal pyramids, you know it. So this tip of this pyramids are called as a papilla. The tip of the pyramid is called as a papilla. Already in the papilla region, there is less blood supply. Because of this vaso-occlusion, there will be further reduction of blood supply that will cause the necrosis in this area, necrosis in this tip. That is called as a renal papillary tip necrosis. Okay, renal papillary necrosis can be seen. That's the important point. Next, the blockage of the blood vessels in the lungs, okay, will cause acute chest syndrome. Okay, so blockage of the blood vessels in multiple areas will cause a pain crisis. The patient is going to have the pain. So these are some important points which I want you to know. So pain crisis will be there, renal papillary necrosis is going to be there, osteomyelitis. Okay, yeah, autosplenectomy, dactylitis, all these are the important points which I want you to know. See, other important point is, what is the difference between sickle cell trait and sickle cell disease? Okay, sickle cell trait and sickle cell disease. See, actually, where is the problem? The beta globin gene. Okay, in the beta globin gene. So, how many copies of beta globin gene will be there? One from the mother, one from the father. See, beta globin gene is present on chromosome number 11. Chromosome number 11. See, imagine this is chromosome number 11 from the mother and 11 from the father. So, this is the beta globin gene and this is the beta globin gene. For example, only one beta globin gene is affected. Okay, one beta globin gene is affected. Okay, it is mutated. So, in RBC, the patient is going to have, see, from this, it's going to code for the sickle cell hemoglobin. And there is also normal globin gene. Normal globin gene is there. It's going to go code for normal globin genes. So, is also going to have hemoglobin, normal HP. Okay. So, if a person is having 50% this and 50% this. Okay, 50%. Then it is called as sickle cell trait. Sickle cell trait. If both the genes are mutated, if both are gone, okay, both are mutated, now there is only, see, if there is 100% sickle cell hemoglobin, then it is called as sickle cell disease. Okay, so I just want you to know what is the difference between sickle cell trait and sickle cell disease. Because sickle cell trait is a milder condition. It's a milder condition. Sickle cell disease is more severe condition. It's a more severe condition. Okay. So in the sickle cell patients, there is going to be excessive hemolysis that is happening. You know, excessive hemolysis is going to cause hyperbilirubinemia, unconjugated bilirubin levels will increase. There can be gallstones, there can be jaundice. Okay, all these things can be seen. So how to confirm that this patient is having sickle cell anemia is HB electrophoresis. Okay, HB electrophoresis. If you do HB electrophoresis, you can find out sickle cell hemoglobin. You can find out the sickle cell hemoglobin cell. Okay, so it's also completed, done. Okay, all the symptoms are going to be same. See, symptoms are going to be same, but what is difference is the laboratory picture. Okay, sickle cell RBCs are going to be seen. HB electrophoresis is going to show sickle cell hemoglobin. Then after this, let's discuss about, okay, the two things which we have completed. Now we have completed in the normocytic anemias. We have completed the peripheral destruction anemias. Which peripheral destruction anemia? Extravascular hemolysis, that is in the spleen. What are the two examples? Hereditary spherocytosis and sickle cell anemia. Now let's discuss about intravascular hemolysis, the hemolysis happening within the blood vessel. Okay, so first let me write important points about intravascular hemolysis. Means destruction, RBC, destruction in blood vessels itself. Okay, RBC destruction within the blood vessels itself. RBC have to destroy for every 120 days. Okay, the turnover should be for every 120 days. What if the RBCs are getting destroyed for 40 days within the blood vessel itself? Okay, within the blood vessel itself. Now look here, RBC destruction is going to cause the release of hemoglobin. Now the hemoglobin is not there in the spleen, sir. Now it's not there with the macrophage. Now directly hemoglobin is seen in the blood. So that is causing hemoglobinemia. It's going to cause hemoglobinemia, or hemoglobin in the blood, hemoglobinemia. Now this hemoglobin is a protein, right? Hemoglobin is a protein which is rich in iron. Okay, which is rich in iron. Now the moment hemoglobin is released into the blood, this hemoglobin is binding with, okay, hemoglobin is going to bind with a protein called as haptoglobin. It's going to bind with haptoglobin. Normally haptoglobin is present in the plasma, it's a plasma protein. The moment hemoglobin is released into the blood, it is going to bind with the haptoglobin. So what happened to the serum haptoglobin levels? Serum haptoglobin levels are going to go down. So if you see this, haptoglobin levels are going down. Okay, think about it. It's an intravascular hemolytic anemia. See, one thing I want you to know, in extravascular hemolytic anemias, that is hereditary spherocytosis and sickle cell anemia, it's a predominantly extravascular hemolysis, means mostly 90%, for example, take 90% extravascular hemolysis, but still 10% of intravascular hemolysis will also happen in sickle cell anemia. Some cells will die, will because of the membrane damage, some cells will undergo hemolysis within the blood vessels also, but small percentage. Right now I am discussing about intravascular hemolytic anemias, means predominantly intravascular hemolysis, but here also extravascular hemolysis will occur. Okay, don't be so rigid about intravascular means only within the blood vessels, extravascular means only within the spleen. Some degree of flexibility will be seen. Okay, so serum haptoglobin levels will go down. See, this hemoglobin will leak into the kidneys. Okay, it will filter into the kidneys in the nephrons. It will come out in the urine. Okay, causing hemoglobin urea. Okay, hemoglobin urea. Now this hemoglobin, as it's getting filtered into the nephrons, some amount of hemoglobin will be reabsorbed into the PCT epithelial cells. For example, look here. This is the nephron. Here, these are the PCT epithelial cells. Okay, here I am not showing any brush border, but these are the PCT epithelial cells. Now, as the hemoglobin is leaking here, this hemoglobin will be reabsorbed into the cells. The cells will try to reabsorb this hemoglobin to get the iron back, because we cannot lose the iron. Okay, we cannot afford losing the iron out of the body. So in order to get the iron back, the hemoglobin is getting reabsorbed. Now this hemoglobin here, it is going to get breakdown. Okay, hemoglobin will be converted into hemosiderin, the iron pigment hemosiderin. After few days, these cells will also denuded. Okay, as their turnover is coming, these cells are also turnover. Now the cells are having what? Hemosiderin. They are containing iron pigment, hemosiderin. So that hemosiderin is coming into the urine, so leading to hemosiderin urea. Okay, so in a intravascular hemolytic anemia, the points which I want you to know is these patients will have hemoglobinemia, serum haptoglobin levels will decrease, they will have hemoglobin urea and hemosiderin urea after days after hemolysis. Okay, so these points which I want you to know for your exam. Now after this, what else I should teach you is the examples of hemolytic anemias. Okay, the examples. The first example that I am going to discuss is paroxysmal nocturnal hemoglobinuria. Paroxysmal, the simple thing, nocturnal hemoglobinuria. Let's write one by one. Paroxysmal means sometimes. Okay, sometimes. Nocturnal, during night, there is red color urine that's coming out. Hemoglobinuria. Why, sir? What's the problem? So this is an acquired condition. Okay, this is acquired defect. So this is the one acquired defect. It's not there by birth. The patient will acquire it. Okay. So acquired defect. Where acquired defect in myeloid stem cells. There is acquired defect in the myeloid stem cells. What is the defect? Let me tell you. Acquired defect in stem cells. The problem is, sir, normally on all your blood cells, okay, all your blood cells, there is something called as GPI. For example, look here, there is something called as GPI, glycosyl phosphatidyl inositol. Okay, this lipid anchored protein is there. There is this protein called as glycosyl phosphatidyl inositol. And it's present on all your blood cells, RBC, WBC, platelets, it's there everywhere. It's there everywhere. Now, to this, who is attached? Look here, guys. To this, there is something called as DAF and MIRL. Okay, two other structures are attached, DAF and MIRL. So let's write one by one. What are these? First one is GPI. GPI, it's a lipid anchored protein. The blue color one is the GPI. And what are these green color things? They are DAF, decay accelerating factor, and membrane inhibitor of reactive lysis, MIRL, MIRL. Okay, DAF and MIRL. Okay, decay accelerating factor and membrane inhibitor of reactive lysis. One is CD55 and one is CD59 positive. Sir, what is the function? Okay, RBC is there, GPI is there, DAF is there, MIRL is there. What is the function? See, this DAF and MIRL, they inhibit complements. Okay, they inhibit the complements, you know it. When the activated complements, the membrane attack complex, once the complements are activated, yes, by producing the membrane attack complex, they will kill the bacteria. Yes, the activated complements can kill the bacteria, no doubt. But these activated complements, they can also attack RBC, WBC and platelets. Every time say these activated complements are like blind soldiers. They do not know what is self and what is non-self, what is foreign and what is native. They do not recognize, they cannot differentiate. Once the membrane attack complex is there, this membrane attack complex is going to attack the bacteria, fungi. They can even attack our RBC, platelets and as well as the WBC. So our blood cells should be always careful. Our blood cells should always protect themselves from the activated complements. There are activated complements everywhere in the blood. Now these RBCs have to protect themselves. So who is going to protect? So this DAF and MIL, they will inhibit if any activated complement is coming towards them. Inhibits. They inhibit the C3 convertase, they inhibit the C5 convertase, they inhibit the MAC. So they are protecting themselves. But what problems in paroxysmal nocturnal hemoglobinuria is, sir, there are RBC, but GPI is there? No. So there is no GPI, no DAF, no MIRL. Now the RBCs is not having any shield, no protection. So what happens, sir? During night, okay, so it's a hypothesis. During night, what happens is we will be doing shallow breathing. Okay, we will do shallow breathing, sir. So usually when you do shallow breathing, carbon dioxide will accumulate in your body, that will react with the water, forms H2, CO3, carbonic acid. So this carbonic acid is going to cause acidification of your blood. Okay, acidosis. So with this acidosis, our complement proteins are activated. Okay, during night, yes, complement proteins are getting activated. Now this activated complements, in you and me, not a problem, because our RBCs are having a proper GPI, DAF and MIRL is there. Now this activated complements, now they are going to the RBC. Now they will cause the lysis of the RBC. They will cause the death of the RBCs within the blood vessel itself. They will cause the hemolysis. Okay, not only RBC, but also WBC will be damaged, platelets will be damaged. Okay, so that's why sometimes, okay, during night, why night? Acidosis during night, there is hemoglobinuria. The RBC is getting destroyed, hemoglobin is coming out of the RBC, and this hemoglobin, it's coming out in the urine. So hemoglobinuria, I have said you, intravascular anemias are going to present with hemoglobinurias. Okay, it's going to present with the hemoglobinuria. So done, sir, completed. Now what is the test? The screening test is sucrose test. Okay, sucrose test, sir. The sucrose test is going to cause the acidification of the plasma. That acidification will cause RBC destruction. Sucrose. Okay, sucrose test is just the acidification of the plasma. When you do acidification, that will cause the hemolysis. You are seeing whether the hemolysis is occurring or not. So sucrose test is done. Now the confirmatory test, best test. Confirmatory test is going to be flow cytometry. Flow cytometry. So what exactly we are looking at this flow cytometry is, so in flow cytometry we are going to check for all the components, whether all components are there or not. In flow cytometry we can very clearly say that the GPI is absent. If you do the flow cytometry, it will check for all the components, of the RBC. Simply you can say the GPI is missing, DAF and MIRL are missing. Okay, so these are some important points which I want you to know regarding paroxysmal nocturnal hemoglobinuria. Okay, you know it, like what you can see in the labs. Okay, the most important point is, what is the most common cause of death? If you ask me what is the most common cause of death, say during night, not the RBC destruction that is going to kill the patient, it's the platelet destruction. The platelets will be destroyed. Okay, platelets destroyed. So the platelet contents are going to cause the thrombosis. So this thrombosis is the one which can actually kill the patient. Intravascular thrombosis can lead to pulmonary embolism that can actually kill the patient. Okay, so these are the points which I want you to know. Most common cause of death, and these patients, okay, with the paroxysmal nocturnal hemoglobinuria, they are at risk of developing, okay, cancers. Which cancers? These patients are at risk of developing acute myelogenous leukemia. Okay, AML risk. There is a 10% chance that these patients can develop the AML in the future with the addition of the mutations. Already they got one mutation, because of that they lost GPI. They can get additional mutations, they can turn into, they can get cancer. So this is also completed. Next, the last topic for today is G6PD deficiency anemia. G6PD deficiency anemia. Sir, why G6PD deficiency anemia? See, our RBCs, let's put it as simple as possible. Our RBCs are continuously under oxidative stress. Okay, continuously under oxidative stress. Sir. There is always free radical production. Okay, H2O2 production is there. Okay, H2O2, hydrogen peroxide. There is continuous H2O2 production is there. Okay, now what we have to do is we have to convert this H2O2 to water. Okay, let me put it this way. Let me erase the RBC. Now what we have to do is we have to convert these free radicals. Otherwise, these free radicals are going to cause membrane damage that will cause the hemolysis. Now, in your RBC, continuously as the RBCs are carrying out this oxygen will be converted to superoxide will be converted to hydrogen peroxide. Right now, I am showing you the hydrogen peroxide, H2O2. What we have to do is we have to convert this H2O2 into water. Okay, let me put it this way. We have to do it. We have to convert it into water, sir. Okay. For that purpose, who is going to help us? For that purpose, the glutathione is helping. Okay, glutathione. So this is the reduced form of glutathione. So it's the reduced form of glutathione is helping in the conversion of H2O2 into water. During this process, the glutathione itself is getting oxidized. It's taking the oxygen, it's getting oxidized. So it becomes, this is oxidized form. Okay, this is oxidized form, this is reduced form. Which form of glutathione is needed for us? Reduced form. So glutathione is acting like an antioxidant. It's a very good thing. It's a very good thing. Okay, glutathione is good. It is helping in the conversion of hydrogen peroxide into water. During that process itself, it's getting oxidized. So what we have to do, we have to again generate this reduced form of glutathione. So who is going to do that job for us? It is NADPH. Okay, NADPH. So NADPH is going to help in the regeneration of glutathione. But for the production of NADPH, what do you require? You require an enzyme called as G6PD. Okay, you require G6PD, glucose 6-phosphate dehydrogenase. Okay, you require glucose 6-phosphate dehydrogenase. Whenever this glucose 6-phosphate dehydrogenase is not there, no NADPH, no glutathione. If glutathione is not there, the free radicals are going to increase in the RBCs. These free radicals will cause damage, RBC damage. Okay, RBC damage or hemolysis. Where hemolysis? Within the blood vessel itself. Within the blood vessel itself, there is hemolysis, sir. Okay, so now imagine there is a patient who is having, okay, deficiency of this G6PD. He is having deficiency, but still he is like, carrying on his life, like, it's going on. But when you increase the oxidative stress, okay, so in conditions like oxidative stress, like during infections, okay, during infections, more production of reactive oxygen species are using certain drugs like sulfur drugs. Okay, sulfur drugs like hydralazine, okay, sulfonamides, sulfur drugs, are eating certain kind of foods like beans, fava beans. Okay, fava beans. So they increases the oxidative stress in the body. Okay. Now I am the person who is having G6PD deficiency. Already I am having G6PD deficiency. Now they are going to increase the oxidative stress, increase the production of free radicals. Now there will be more hemolysis that's going to happen. Now the patient is going to develop hemoglobinemia, hemoglobinuria, hemosideриnuria. The serum haptoglobin levels will go down. Okay, all these things are going to be seen in this patients. The one important point which I want you to know is, sir, this free radicals H2O2, what it is going to do? See, this H2O2 oxidative stress, it's going to cause precipitation of the hemoglobin. Okay, precipitation of hemoglobin. Okay. Now, if you look at this is the RBC, the hemoglobin will be precipitated. Now, precipitated and is going to look like a bodies. Okay, like small bodies. So these bodies are called as this precipitated hemoglobin. Okay, this precipitated hemoglobin is called as Hinz bodies. Hinz bodies. Now, when such RBCs, okay, when such RBCs with the Hinz bodies, okay, with all these spots, when they are going through the spleen, spleen always want good RBCs, good, nice, beautiful RBCs. When such hinge bodies are there, what spleen will do? Spleen is going to take a bite. Okay, spleen will try to remove that area. So spleen, now it's trying to remove this area. So what happens? RBCs are going to look like this. RBC is there, but now it's going to have a bite over here. Okay, now that is removed. That area is removed. For example, the place where the hinge bodies are there, that area is removed. Splenic macrophages. So now it's going to just looking like the splenic macrophages have taken a bite out of the RBC. So these are called as bite cells. Okay, these are called as bite cells. So bite cells are seen in, you know it. Okay, bite cells are going to be seen in G6PD deficiency anemia. Hinge bodies are seen in G6PD deficiency anemia. Okay, G6PD deficiency anemia, intravascular or extravascular hemolysis, intravascular hemolysis. Within the blood vessel itself, the RBCs will be destroyed because of the oxidative stress. That oxidative stress is going to cause the membrane damage. That membrane damage is going to be so severe that because of the damaged membranes, the plasma will enter into the RBCs. That will cause the swelling up of the RBCs and there will be rupture of the RBCs. So the RBCs will die within the blood vessel itself. Predominantly intravascular hemolysis. Of course, some amount of hemolysis will anyway happen in the spleen, but predominantly intravascular hemolysis. Okay, so these are some important points which I want you to know. So with this, our today's topic is completed. What we have discussed is G6PD deficiency anemia. We have discussed about nocturnal hemoglobinuria, paroxysmal nocturnal hemoglobinuria. We have discussed about sickle cell anemia, hereditary spherocytosis, this B9 deficiency anemia and B12 deficiency anemia. Okay, in the tomorrow's class, let's discuss a few more important topics. Let's do the platelet disorders also tomorrow. Hope the class is helpful. See you tomorrow. Thank you.